To give us some perspective and context, and perhaps a bit of historical context too, we asked Christine Bennett to present as our first keynote after the Minister. Christine is Dean of Medicine at the University of Notre Dame. She's got one fewer job at the moment, as she's no longer chair of the board of the National Preventive Health Agency, since that no longer exists. She chaired the National Health and Hospital Reform Commission, which set in train a whole series of reforms, not quite as Christine envisaged. Politics got in the way, but primary healthcare reform, as well as hospital reform, and the reforms that are flowing through the system and have been the topic of previous discussions at this forum in the last two meetings of this group. And now we're moving on from there, but it's good to know on what shoulders we stand as we move forward and get some analysis of the current context. So please welcome Christine Bennett.
Thank you, Norman. And what many of you may not know is that Norman and I are paediatricians, and in fact he was my registrar and taught me to think big and ask lots of questions. So thank you very much, Norman. Well, good morning, colleagues. I would like to start by also acknowledging the Gadigal people of the mighty Eora Nation, whose land we are meeting on today, and to pay my respects to elders past and present, and also a very special acknowledgement of any First Australians here with us today. Thank you for your support. There's a lot to talk about today. A lot's happened in the last month with federal budgets and, of course, this week's state budget. And health reform has always been a journey, as you know. So my presentation is going to focus on some of the things that are perhaps changing in the landscape of health reform at the national level, and then Dr. Foley will be taking us through more detail about the relevance to us here in New South Wales. Now, health reform is a journey, we all know that, and so I'm going back, casting our mind back to the beginning, back in 2008, where a group of 10 commissioners, an independent commission, went boldly into uncharted territory. We went to the front line of the health system, and we knew the challenges and the pressures on public hospitals. We knew there were safety and quality concerns. We knew that our system dealt with many problems very well, but if you had a chronic disease, and there were more and more chronic diseases, that it didn't treat you well, it didn't necessarily get you the right care in the right place at the right time. We knew that healthcare costs were continuously going up, and yet we had a sense that we weren't as efficient as we could be. An ageing population, but also a growing population, and importantly, costs from the volume of care and the technology that we were making available in care, driving those costs up. So there was a lot to consider, and I think that it's good news that the current federal budget has, current federal minister has acknowledged that this body of work is a great reference point and has clearly read the report. And I think that it's important because it wasn't 10 commissioners, it was tens of thousands, many of you who contributed to the ideas. And really what we need to focus on now is what are we actually doing from that. And of course, we've got a changing political context, which brings sometimes new thinking, changes in direction, but it is important for us to revisit and consider what we're doing and are we achieving our policy directives. So I'm going to point you back to that original reform document, because I think it really was developed for a decade or two of information and aspiration. And I still use this construct of discussing the themes of reform. So it's not just about describing what's wrong with the system, it's what do we need to do about it. And the 4 themes that we talked about provides a good construct to discuss the actions that are needed. So the first theme was about taking responsibility. Secondly, connecting care, or integrated care, as the Minister just called it. Facing inequities and driving quality performance in our system. We had 123 recommendations and we had 108 accepted and 14 noted. Last year I did a review called Are We There Yet? Of the journey of reform, and it showed that many of them, the recommendations, were being somewhat implemented, perhaps differently to envisaged, but a lot of activity going on. So the big question is, where are we now? So we've gone from are we there yet to where are we now in our journey of reform. The first theme was about taking responsibility, and this was about our own individual as well as collective responsibility for our health and the health of others in the community, whether as individuals, parents, employers, health insurers, clinicians. We all have a role in healthcare. And this theme emphasised that health is about more than healthcare. It is about how we live our lives, it's about the environment we live in, and it's about our own understanding and decision-making in our healthcare. So the various things that were recommended and implemented, and the update on them is that the Prevention Agency, as Norman said, was established and has been abolished in May this year. The work on tobacco, alcohol and obesity, which were the main aims of the agency's work, we've had a reduced investment across the board federally. The Healthy Kids, Healthy Communities and Healthy Workplace National Partnership Agreements also ceased this year in the middle of their course. The Healthy Communities Report, and I want to have this very balanced because there are good things. The Healthy Communities Reports that are available at a local level have provided some great information for action on local community health. And the World Health Organisation social determinants was something also that we were emphasising as new work that needed to be looked at if we're serious about the health of our nation. Personal controlled electronic health record also fell into this space because our vision for the person controlled electronic health record was that it was person controlled, that the person sat at the centre of this strategy, and it gave a person the access to the health information that's most important to them, which is their own health information. It was then going to be useful to the clinicians and the various providers of their care to, as the Minister said, reduce the duplication errors and improve the connection and continuity of care. Now, the good news on this is that there is a progress of review, there is an investment in the forecast, and I think this is one of the strategies that I'm really looking to with great hope because we have not yet reached the potential of this. Connecting care was the second theme, and this was about the comprehensive care across someone's lifetime, right from a healthy start to life through to aged care, and all the elements of the health system that were needed. And our key finding here was that the pressure on public hospitals was the solution lay largely outside hospitals. And so the focus on beds and doctor numbers was not looking at the whole continuum of care, including health risk management and early management in primary care, specialist care in the community, specialist subacute care services, and also right through to aged care. So the recommendations that we had and the update on them, the GP super clinics was akin to our recommendation on comprehensive primary care centres. That program has ceased. The primary care health organisations, we call them, which are Medicare locals in current parlance, will transition to primary care networks. Still a lot of detail to be worked through on what that means. I think there is a potential for primary care networks to be successful, but it will require very close consultation with states, in my view, because the real potential for the primary care networks is a local focus on communities and the connection and bridging with the health districts and also aged care, as well as other groups within the community like councils and schools and businesses. So that's a space that we're yet to see complete detail on, and is really critical, of course, to our integrated care strategy. You may have forgotten there was a thing called the Voluntary Enrollment of Diabetes pilot, which was really about how we might finance care for chronic disease in the primary care sector. Haven't yet got the results of this. I know it's actually been progressed, and I know that there's a group who are conducting the evaluation. And just to remind you all, this was saying rather than just a straight fee for service on activity, there would be an additional registration fee for people, for a practice, if people registered at a primary care practice that was credentialed to have this sort of service, as well as the practice getting an incentive payment for quality and outcome, as well as the patient getting a bundle of benefits that could be tailored to their specific needs. And the idea was to see whether you could actually then enhance the right care over time with a focus on outcome and in a primary care setting involving multiple professionals. I'm hopeful that that will actually produce some positive results to look at how we might reshape Medicare into the future. Subacute care, the missing link, as we called it, really important. We knew that partnership agreement was being completed this month, but I really have to congratulate New South Wales Government and New South Wales Health for continuing that program, because really you don't want people who need care in these services in a hospital bed or worse still, not surviving, not recovering because of the absence of those services. And I include in there the palliative care services that New South Wales is investing in, which I think is often very forgotten. So very good to see that happening. A new element in this connecting care is the co-payment that has been proposed and is much debated. I'm going to talk a bit more about that later. But so that's the connecting care theme, which aged care, I'm not across the detail, to be honest, but it looks like that many of the elements about consumer choice and opening up the industry are being continued. And that's important because the aged care environment definitely impacts on health services and vice versa. And I always like to emphasise that we talk about the bridging between primary care and hospitals, but it's also with aged care as well. It's a sort of triumvirate. Facing inequities, our third theme, which was about saying we have some real health inequities. The system is good for most people most of the time, but there are definitely gaps in our system and groups who miss out. And the first, of course, are our first Australians. And while I am not across the detail, it does appear there continues to be a focus on closing the gap from the federal government point of view, although there is a rationalisation of Indigenous affairs, which I haven't got a lot of detail on. But in fact, there's also some new investment being proposed in Aboriginal and Torres Strait Islander health. Not quite the case for dental. We are looking at reductions in dental funding, particularly through the state programs that were being put in place. Mental health, there is a net increase. The Partners in Recovery has been ceased, but there is a net increase overall with a new National Centre for Youth Mental Health Excellence and also increased investment in Headspace. And rural health does continue to have a major focus for the third of Australians who live in a rural and remote area. There are some new programs, particularly around improving workforce and access to services. The National Disability Insurance Scheme I can't take credit for, I really wish I could. We did mention disability and we did talk about a Medicare Select style, and really the National Disability Insurance Scheme is like a Medicare Select style of program. It will be continuing, it has had bipartisan support. The big question is, what is it? What is it? What is it going to do? Exactly how it's going to be funded? Are all questions still being worked through. Right, the final one, driving quality performance. So this was about the leadership and systems that we need to achieve the best use of people, resources and our evolving knowledge. This was the one everyone wanted to jump to during the Commission, really about governance, what were the Commonwealth and state arrangements going to be, financing, our workforce, of course, our infrastructure, including our data and our research infrastructure. So that's the theme that is about driving quality performance. Where did we land? We landed on the fact that we were a very, very complex system. This is the simplified version of how the funding flows, and that took 10 of us with a number of health economists and we had a noodle nation up on the whiteboard. But it is a very complex system, and the fragmentation in both the financing and governance often gets in the way of a person getting the right care in the right place at the right time and over time. And also limits the abilities that different parts of the system have to integrate, to connect. So that's was one key learning. The other was that the changing share of Commonwealth and state funding was very much related to the pressure on public hospitals. It's not exactly rocket science, this one, and it's called the vertical fiscal imbalance. In that, for health system sustainability, the theme of today, you need to have governments responsible for elements, or possibly in the case of the Commission's work, a single national public funder that actually has the means and the resources to meet the growing healthcare costs. That's not to say that there aren't opportunities to reduce those costs, to get better value for money, to bend the cost curve. But with the current rates of growth, it was shown that states could not, over the longer term, support the growing costs of hospitals from their revenue base. So this is very simple. It's what I call the emperor has no clothes moment, that right now we've got a New South Wales government filling the gaps and keeping the reform momentum going. But in the longer term, we really need to look at a longer term solution for the funding sources, and so that we can actually get a whole of system view rather than a fragmented view. So way back then, the response was, in 2011, that there would be a compact between the states for a reform package. There'd be these national partnership agreements, which you've just seen have wound up. We'd have a basis of efficient activity-based funding to determine the increasing growth share, or share of growth, that would be contributed by the Commonwealth. And as you know, that was 45% from 2014-15, and then from 2017-18, it was going to be a 50% share of growth, which, if you're a mathematician, you'll know that if you're starting around 30% and you have a 50% share of growth, you actually never get to 50%. So, it gets pretty close in the 2060s. But it was a strategy to have a slowly increasing and understood growth in Commonwealth share of the hospital funding. There was a commitment to the performance monitoring. The states set up their local networks. The Commonwealth set up the Medicare locals, which were to bridge and help integrate. And there were some national bodies focusing on our workforce through APRA and HWA, quality across the whole system, including the private sector, and prevention. So in the federal health budget this year, what has changed? The national partnership agreements, as we've said, have ceased. The removal of the minimum growth guarantee, which was part of the states understanding what the future growth contribution would be from the federal government, has also been removed. The 45% of growth from 2014-15 has been preserved for 3 years. And then after that, it'll be CPI and a growth formula based on population growth. The need to abolish and merge bodies. By the way, I actually think merger of bodies and reducing red tape is something that we need to look at. You need the additional costs of running group agencies to actually deliver additional value. We've got Health Workforce Australia going into the Department of Health federally. My concern there would just to be ensure that it does have a whole of system connection with the states, who obviously are the major providers of training and education, as well as the private sector and the non-government sector that are increasingly going to have a role in the ongoing training of health professionals. ANFA is abolished. I'm not going to harp on it. The Safety and Quality Commission, IPA, NIPA and AIHW are merging in some form, being worked through to really have a focus on performance and productivity of the health system. I think this is an opportunity. It's a great opportunity if we focus on the relevant dimensions of performance and productivity. and make sure that we see it as system-wide, particularly private and public sectors. Medicare locals are to transition to primary care networks. We actually are having an integrated care day tomorrow with the boards of the health districts and our executives, along with the Medicare locals. I guess the elephant in the room will be, with all the partnerships that are being developed, what will happen as we move to primary care networks. But I think it's also an opportunity for us to take a lead and lets us, the people actually running systems, put to the national government what we think should happen there. The new co-payments. Now, the new co-payments, which are across the primary care, the general practice setting and diagnostics, I'm sure you all know the details, so I don't need to explain it, but it's a $7 co-payment, $2 of which is retained by the practice, and $5 of which goes into the savings that I'm going to show you in a moment. That goes into the Medical Research Future Fund build. In fact, all the savings that we've been discussing go into the Medical Research Future Fund. I suppose the thing about the co-payments is I'm still unclear about whether the purpose of the co-payment is to deter the worried well, to make people think twice before they go to a doctor, or if it's a philosophical point of view, which is a legitimate one, to say that in all forms of insurance there's often a co-payment at the point of service, and that's a way of the users contributing differently to through their social or public insurance system. But whatever the purpose is, I think it's really important that we understand what a co-payment might do and who it might do it to. I was meeting with some folk last night from Queensland who assured me that their practice volume had reduced by 20% in a general practice up there, and that the local hospital was seeing a lot of additional presentations. A lot of anecdote, not really sure of the facts, but I think it is really important to make sure that people who need immunisations, need their cancer screening, are on a chronic care plan, are in an aged care facility, don't have any deterrent that might mean they don't get their care and end up impacting their health as well as pressure on the health system. And then the Medical Research Future Fund, which is really the shining light and frankly is something I'm very excited about, Chair of Research Australia hat on, to say that this is an ambitious investment, and I think one that will be very good for Australia, both in terms of our health but also in terms of the economic benefits. If in developing and then investing that fund, we do it in a way that captures those health benefits here, and importantly the economic and business opportunities from the great discoveries and invention and devices that we produce in this country. This is a summary I thought I'd put together from budget papers, just of some of the pluses and the minuses. Now, in each of these, medical research, that's not the Medical Research Fund, that's just the over the forward estimates period, some additional funding that was going into research. The MBS has got lots of ups and downs included in it, so that includes the simplifying of Medicare as Medicare safety net, the reduced optometry rebates, of course the introduction of the co-payment, which reduces the MBS item payments, and the pausing of indexation. So that's a pretty big one, that $5.5 billion. The primary care networks is cost neutral because the funding is just going to be used in a different way. Hospitals, that mainly relates to overall the hospital agreements. So you can see that the state share, if you like, is quite significant over the forward estimates period. The pharmaceutical benefits, largely to do with co-payments, is that negative there. Workforce, there's some ups and there's some downs, particularly some ups in rural areas, and some savings from HWA, overall a net increase. Mental health, there are many ups and downs. The Partners in Recovery funding is reduced, but the Headspace and other developments are increased. Dental, I haven't heard any comment about teeth, but teeth have, mouths and dental health have not done well. And that's just basically removal of the programs that were in place. Prevention, that saving there from the prevention programs is through the national partnership agreements, but there is some good news in the sense of the bowel cancer screening prevention being made national and fully rolled out. And for the abolition saved 6.4 million over the forward estimates. And flexible funds, which are various programs overall, largely through pausing indexation, causes those efficiencies there. PCEHR, an investment next year, and Indigenous Affairs rationalisation. I'm just taking you through this because there's lots of ups and downs in it. When you add in sport, which has an up of about 300 million, the total saving across the whole portfolio is 8.5 billion, which goes to the Medical Research Future Fund. Now, this week was the state budget, as you know, and I liked this nifty graph there that showed that what we call the fiscal gap has increased as largely, if you look to that right there, the light blue one, that is the gap caused by the changes in the contribution from Commonwealth funding. But if you take a longer term view, this is the change in the gap of Commonwealth funding. So I am placing a lot of emphasis on the importance of the Federation white papers for white papers in Federation and also tax reform, because that clearly won't be sustainable and we need a solution. And by the way, I do just say, it doesn't mean we don't keep trying to examine the cost drivers, get more value for the healthcare dollar, reduce waste and inefficiency, and understand our system and make it work better, which could reduce that overall need. But the pattern is there. So these were the statements made in the Commonwealth of Australia's budget papers, which really does then, I think that last paragraph is the important one. It is talking about states and the Commonwealth as independent sovereign entities being able to do the role that they have. Revisiting those roles, revisiting how those roles are supported by funding, and the tax structures. This is the most important thing I think that we can do at the moment for the next 3 years while we're in a holding pattern of 45% growth. So really looking at how we can influence the structural changes for a sustainable future and the collaboration between our two main levels of government. And that just shows they're looking at across different areas, health being the third from the right. It's pretty shared sort of, costs there of the system. So I'm just summarising now by saying what I see the challenges are, and of course challenges always turn into opportunities, so we're going to leave on a positive. The change in the Commonwealth funding contribution, the widening fiscal gap. I think we've made that point. The uncertainty and reduced transparency, one of the things about the plan was that we knew where we're heading. We now need to act very quickly to understand what the future will look like through those Federation white papers. The national prevention leadership, with ANFA abolished, there is an opportunity for the national groups who were working together to provide leadership in another way. The health workforce planning, the challenge is making sure that it is genuinely national, it's public and private, includes the educators as well, the colleges, the universities, the vet sector. The Quality Commission, just again, making sure that the public and private sector are in the purview of that very important area of improving the quality of our system. The copayment may put pressure on public hospitals, if it in fact does drive activity from general practice to hospital emergencies. Turning that all around. As the Minister said, New South Wales has the biggest electronic health system in the country, is well progressed with Health eNet, and I think well positioned to take a lead role in shaping the PCEHR strategy, but also blending that with what New South Wales is doing. Prevention, you could have some state leadership. I certainly know Kerry Chant is on the case, and with a lot to be done with local communities and a state level. The primary care networks, again, try to shape the agenda for integrated care, put forward the solutions of how this could look and how it could work without losing the subsidiarity, the localness of the structure, whilst gaining the economies that the federal government are trying to look to do in the fewer infrastructure bases of primary care networks. Co-payments, just throwing this out there. I know the government has said there will not be co-payments, but I wonder if this is an opportunity for New South Wales Health to look at actually entering primary care in various locations. The ABM portal, people are saying, is activity-based funding dead? Well, no, it's not. And actually, it is an achievement already that all the states in this country are enabled with and are using activity-based funding, admittedly in different ways, but it provides a data and a valuable tool for not only the volume price purchasing that the states do with the hospital districts, but also understanding our activity and a lot of clinical dimension as well. So the activity-based management portal, I think, should be adopted by the other states, stolen with pride, as they say, by the other states. And there's a lot more to do with smart use of data. Just would really like data linkage to finally happen at the federal level and be made available. The health productivity and performance entity may well be able to do that, push for the data linkages that we've been long wanting from MBS, PBS and hospital data, public and private. But the opportunity here is for the state to ensure there is a proper relevance to what we're measuring, and it isn't all about the waiting times in emergency departments and surgical waiting lists. It's about how long a young person in mental health crisis takes to get urgent care. It's about getting speech pathology for a birth person with a brain injury. It's about stroke rehabilitation and actually getting that care in a timely way. It's about many other dimensions, even getting to see a GP when you need to. So, big hopes, big opportunity, white papers for the reform of federation and tax reform in this country. And let's really try hard to get this quintessential Australian issue sorted for one of the most important areas to Australian people, which is health. And let's take up the opportunity of the Medical Research Future Fund this is how it grows over time, so that out there in the 2020s you're heading toward $2 billion a year with the NHMRC funding as well. Let's make sure we're embedding that in the health system. Let's make sure we're got health systems and health policy research in that, and let's make sure we do things like New South Wales is doing with the Medical Devices Excellence Awards, actually getting great commercial ideas into action. And there's some references. This has been made available to you, and questions and discussion. I did want to just close by emphasising, prior to Dr. Foley's presentation, that I was actually impressed, this is true, that the state health budget has filled the gaps, has actually maintained reform momentum, and is particularly staying true to the strategic elements like integrated care, the palliative care, data and e-health, and new things like the genomics. And that's a really important example from Australia's largest health system. And I'm very happy to take some questions.